So today I'm going to talk a little bit about endometriosis, which has been in the media a lot lately, and luckily we have also been granted a lot of funding for endometriosis for diagnosis, for treatment, and also for research. So as specialists who diagnose and treat this condition, we certainly welcome the chat. Now, endometriosis is quite a complex condition, as you may know, and the rates are about 10% in the general population, but if you take the infertile population, it's probably close to about 50%. Now, the cause of endometriosis remains unclear despite years and years of research, and there's probably a genetic component involved, but also some environmental component that makes some people really suffer with symptoms with endometriosis whilst others don't. And this is not particularly related to the severity of the disease that we see. So you could have, a couple of spots of endometriosis and be really quite affected by the symptoms versus having quite significant endometriosis on surgery, but really don't even know that you have it. Sometimes people call this silent endometriosis. So you probably know a little bit about what endometriosis is, but essentially it's when the lining of the uterus, which we shed in a menstrual cycle, goes outside of the uterus. And this can be anywhere really. In surgery, we've seen this on diaphragms, on bowels, on bladders, and even you may know people who've had them on cesarean section scars, for instance. But most of the time, this endometriosis is around the uterus, on the pelvic side walls, or on the ovaries. And if they create an actual cyst in the ovary, it's referred to as an endometrioma. Now, endo is characterized by a lot of symptoms, or no symptoms sometimes. People will complain of pelvic pain, heavy bleeding, and infertility is one of the symptoms. But more and more we really are recognizing that endometriosis patients have many comorbid symptoms in addition to the pain symptoms that they experience, such as fatigue, bladder and bowel symptoms, nausea, headaches, and mood changes. So this can all be part of the presentation of endometriosis. So how does endo affect fertility? Lots of different ways, but it doesn't necessarily mean that people who have endometriosis will have problems with fertility. We know many people who've got endometriosis who've had no issues with fertility or pregnancy. It's just that some people may, and there certainly is a correlation with subfertility and endometriosis. So how can it affect fertility? Well, the inflammation that endometriosis causes can cause scar tissue, for instance, and this scar tissue can distort the anatomy within the pelvis. So essentially it can, twist the tubes or block the passageway from the ovary to the uterus. It can really get things stuck in the pelvis so that there are many barriers for the egg and the sperm to meet. In addition to physically blocking some of the processes, endometriosis can also interfere with the normal functioning of the organs. So it can actually cause the inflammation of the lining, and that inflammation can also be harmful to the egg and the sperm and the embryos. And this can result in poor embryo quality or egg quality as well. In terms of how endo can also affect infertility, you can actually notice that endometriosis can make implantation a problem. So some of that inflammatory fluid that is within the pelvis with endometriosis can seep into the lining really and affect implantation of the embryo into the actual lining as well. Endometriosis is also associated with low ovarian reserve, with sexual dysfunction. So it's actually a lot of different ways that endometriosis can impact on someone's fertility potential. So why do we care if some people can get pregnant with endometriosis and some people can't? Well, we know that early diagnosis and treatment and management of endometriosis can make a difference to pregnancy outcome. So studies have shown that the quicker we do diagnose endometriosis and get on with treatment, the higher chance that someone will have of having a live birth of a baby, and the quicker that process can be, and also that early diagnosis can actually reduce the amount of fertility treatment that someone needs. So for example, the amount of IVF cycles that someone would need. So early and prompt diagnosis and treatment and management is really actually quite important with endometriosis. One thing just to mention, and it might be obvious, but endometriosis in women with subfertility should not be treated with hormonal treatments. I know that seems like an obvious thing, because if we are giving hormones to someone who's trying to get pregnant, then this can obviously hinder them being, conceiving. So if someone was, for example, presents to me who's 25, whatever, 30 years old, and has problems with endometriosis and is not wanting to get pregnant, and one of the treatment options is medical management, so giving the pill, for example, that is great for them when they're not trying to conceive, but of course will not get them pregnant if they are trying to conceive. And it's not just a simple thing. We initially were wondering whether a period of giving the pill and really, dampening that and inflammation would help 3-6 months later with trying to conceive, but really studies have shown that hormonal treatment before fertility treatment, in between fertility treatment, or surgical treatment makes no difference. So really there's no place for hormones in endometriosis and subfertility. In terms of the options for treatment in a subfertile patient who has endometriosis, it is okay to have a period of expectant management. And what we mean by that is just trying to conceive naturally for a period of time, knowing that they've got endometriosis, but not actively trying to treat it. Because as we mentioned, you can get pregnant with endometriosis. Obviously, it depends on the situation. And, I think the key with all of this, that we need to have a chat to our patients and collectively decide what they want to do, and also what is the best option for them. So someone who has a very low ovarian reserve, for example, who's older, we don't have time probably to, just see how things go. Whereas if someone has no symptoms, no pain, we've incidentally found some endometriosis on scanning, for example, and they've just started to try for pregnancy, that's okay to, say, let's give it 3 months and see how you go, and maybe you will get pregnant, and if not, these are going to be our next steps. Other treatments that have shown to be of benefit is Lipiodol flushing. You may have heard of this. Now, Lipiodol is a poppy seed oil-based contrast that you can use by injecting into the cavity. It can be used as a contrast for radiological investigations, or as an actual treatment, or both. For example, if you're doing it in a radiology setting and you know that someone's got endometriosis, it has been shown in the literature to be beneficial for women with endometriosis, and it has been shown to improve fertility. Now, how this is done is we think, obviously there's flushing and getting rid of debris and all of that, but we probably think that there's some kind of immune effect on these actual deposits at endometriosis that we don't quite wholly understand. So I may use Lipiodol flushing in the setting of patients not wanting to go to surgery and just wanting to try naturally, for example. We know that Lipiodol flushing probably lasts for months in terms of its benefit. Or in theatre, I sometimes use it after I've excised endometriosis or treated it, and I actually do the flush in the actual theatre complex. So that's one of the other treatments that we can do. Considering surgery for endometriosis patients, so what about surgery for endometriosis? If a patient is suffering from infertility and is quite symptomatic and has quite significant pain, for example, then surgical treatment is often considered to alleviate that pain and potentially to improve their fertility. Now, once I've excised that endometriosis, then, you know, I might say have a period where you go and try for pregnancy, and, you know, we call that expectant management, to see if you can get pregnant. There has actually been research and there is data to show that removing endometriosis in, you know, stage 1, stage 2 disease, so mild to moderate disease, may actually help with improving fertility outcome. Now, when you're trying naturally. Now, the data is not so clear when the endometriosis is actually very severe. So, for example, you know, involving the bowel, there's all kinds of different classifications that we all use and a lot of medical jargon, but essentially if it's severe endometriosis, the outcomes in terms of removing it and the success in pregnancy rate is not so clear cut. And we do, as in with all of our treatments, really need to individualize that to the patient. So, you know, we take into consideration things like the patient's age, their ovarian reserve, the family size that they want, ideally, you know, how many children that you want, and all of your, you know, the patient's considerations need to be taken into account when we make that decision. So, you know, some people might decide to go straight into fertility treatment rather than have their endometriosis treated at all. And other people might decide to do their endometriosis treatment, for example, especially if they're symptomatic, and go straight into fertility treatment. Now, the evidence and research on the improvements in fertility treatment from endometriosis management, again, isn't so clear at this moment in time. If you watch this video in 5 years or 2 years even, probably everything's different, but certainly at the moment it's not so clear cut, but it is something that we will consider. So if we are going to operate on someone, us as surgeons also have to think about the potential damage to someone with endometriosis and how our surgery might potentially affect someone's, for example, ovarian reserve. So we know, you know, cutting into an ovary to remove the endometriosis, taking out an endometrioma may in fact reduce someone's numbers of eggs. So all of these things really need to be considered and discussed, and together we need to come up with a plan for each individual patient. Some patients, like I said, may very well know that they have endometriosis, but decide to not do anything about it because they have not too many symptoms, and go straight into fertility treatment. However, there are some cases where we would go through to fertility treatment and maybe we find that, I don't know, quality might be affected, or, you know, something where we think maybe treating that endometriosis may actually have some benefit. And that's an ongoing conversation that you and your practitioner should always have, and also, you know, come to an informed decision along the way. In terms of you know, treatment of endometriosis involving the bladder or bowel, once again, the evidence for treating that is not that clear. So I certainly offer that to patients who have really got symptoms. And, you know, fertility is one thing, but, you know, people with really symptomatic endometriosis are going through so much pain and discomfort that my primary thing is to talk to them about, hey, let's just alleviate your pain and symptoms as best as possible with whatever way we choose. And if they're trying to get pregnant, really that doesn't leave us too many options. As you know, I talked about the hormones. So then we might just do, you know, surgery and then go, okay, now how do we address this fertility issue? So endometriosis is really complex. There's no formula. Every single patient is different. Every disease is different. The symptoms that you have is very varied. And I guess that's what keeps the early diagnosis and that discussion of the patient's wants and needs and aims, and, you know, what you can offer becomes really important. And this space will change with all the funding that we're getting and all the research that's currently going on, and that's good and exciting times, and hopefully will benefit our patients for years to come. Thanks for listening.